So, I'm Josh Landy. I'm one of the co-founders of the medical case sharing platform, Figure One. I'm also a practicing critical care physician. And that is a picture of me and my two best friends on the day that we graduated from medical school. I'm particularly happy because it was on that day that I realized that I never had to think about medical education ever again, and I was on my way to a beautiful future. But actually, it really does represent that moment where you make the transition from being a learner to start thinking about how you're going to assume the new role of teacher of learners younger than you, and eventually, in my case, educator. And when it's this moment, and then the very next beat after this, when you are a resident and you're in front of a patient, and in a moment, you have to realize that you don't know anything about this person at all. And in one instant, you have to take all of the knowledge and the appropriate skills and the right expertise and access all of the correct pieces of that in that one moment to be able to focus on what it is that you need to do for that patient. And for me, that moment is where medicine is happening. And I think that this fits neatly into my philosophy about education, or medical education per se, which is that medicine and clinical practice are currently not in phase anymore. Those things should be directly aligned. They should fit hand in glove. But we have structured education, and we have unstructured clinical learning. And those two things don't work together, but they should. And this isn't a realization that I've had suddenly. It's actually one that I've had due to a long series of very disappointing events in my life. And I thought today would be a good opportunity to sort of talk about some of those disappointments and what I think is wrong with the world. This is the circulatory system of a fish. And this is what I was learning in grade 10 science when I encountered something that was extremely, deeply disappointing to me. And it was, learning this was okay. It was going okay. The class was kind of boring, and my teacher was going on and on. And I got to talking to my friend that's sitting next to me about some of the interesting evolutionary adaptations that a fish would have to make given the environment they live in. When we were rudely interrupted by the teacher who said, "Excuse me, no talking in class. If you want to talk, you can get to the front of the class and you can teach it if you want." And she didn't know who she was talking to because I said, "Sure." So I did. And it went really well. It was like the best lecture I've ever given. But I was enthusiastic, and people responded to that. And while I didn't become an ichthyologist, it made me realize in that moment that what had happened was she had sort of unyoked or uncoupled her lesson plan from the goals of the learners in the class. It was more important for her to finish what she had planned to say than it was for us to be paying attention and care about something that was interesting. So the next beat after this was when I was disappointed as a chief resident. And I was part of the undergraduate medical education committee. And I attended one of our meetings, and the director burst in a tizzy, and he said, "All of the second-year medical students are cheating on their OSCE." And I was like, okay. All of them? He said, "Yeah." I said, "Okay. Well, first of all, does everybody in the room know what an OSCE is?" Okay. It stands for Objective Structured Clinical Exam, and it's a station-by-station formative examination where you're put into a clinical scenario and you have to interact with something and then give an answer to a clinical question that relates to that case. And what the students had done is they took this new technology, a wiki, and they had assembled all of the information that they thought would be necessary to conquer all of the stations that were on last year's exam and the year before, and any new stations that they thought of in the moment. And they added those to the pile, and they said, "This is all the information we need to know. If we learn this, then we'll be able to succeed on the exam." And he said, they are cheating because they're walking into the exam with all the information they need to know to pass and do really well. And I said, "What are you talking about? That's your job. They're doing your job for you. These people are learning the exact things that you're supposed to be teaching them. And you're mad because their grades are going to be too good." And that didn't go over super well. Because, and this is my analysis, they were more worried about whether or not this educational experience that they had designed was going to work, rather than worrying about whether or not people were actually learning the material. The third disappointment was when I was in an OSCE of my own as a critical care fellow, and I was asked to analyze the respiratory system of a patient. And then the question was, and what is the respiratory time constant? It's a very technical thing in respiratory physiology, and you learn a lot about respiratory physiology when you learn about critical care, because patients are on ventilators, and that's a really important part of keeping people alive in the ICU. And I was confused when I heard that question. I was confused because after 9 years of medical education and attending patients' bedsides and making rounds and studying textbooks and journals, I had never heard that phrase, time constant, before in my training. Now, look, it wasn't that I didn't know the answer. I don't claim to know everything. And I got lots of other stuff wrong on that exam, and that didn't bother me. But it was like disconcerting in a way that just felt really unsettling. That here's this idea that no one had literally ever mentioned to me before, that never seemed relevant to any single patient's care that I ever cared for before, and by the way, ever since. And this occupied a position worth 10% of that exam. But to one of the points of Rishi, who spoke about self-driven learners, the autonomy of a learner, I think, is the key to harnessing that person's own curiosity and helping them discover what is interesting for them and how you can sort of harness that power to drive their education. Because we should be doing and creating education that fits what learners are doing. Right? There was an amazing talk yesterday, which I didn't attend, but I got a special preview or a post view. Joel Tove talked about the evolution of how text and information is being transmitted in healthcare. And while it used to be textbooks and journals, then it became the web being the dominant way, and now it's mobile. And so what we need to start thinking about is creating tools that are going to meet learners where they are and where they expect to be, and what they need to learn is going to be right in front of them. This is sort of the way that quality improvement researchers think about quality improvement. Make the right thing the easy thing. If your students are taken to a wiki to compile all the information, partner with them. Make sure that they have the right information so they can get the information they need in the moment they need it, because that's why we use mobile devices anyway. And make sure that it's right, and you're not going to hurt anybody. But we're still sort of stuck in the old stodgy textbook era. And whose fault is that? My grandfather. No, that's Abraham Flexner. And he's in a lot of slideshows about medical education because in 1911 he wrote a report that was describing the state of medical education in North America, and instead of taking it as a description, people thought it was a prescription, and so that's how they designed medical schools for the next 50 years. And that's not bad. It's worked pretty well, but we need to start thinking further about what the next era of medical education is going to be, because now that we've got the internet and we've got the distribution of knowledge, that information that used to have to be classified by chapter or by section is now atomized into the environment. Individual pieces of information are accessible. And these individual pieces of information, if we try to map what that means onto education, these are lessons, right? An individual, and in fact, maybe inside a lesson, you have an individual learn, a single piece. And I think that there's a way to map this onto medicine, which is the case, right? An individual case of an individual patient is unique. It has that patient's history, their life, the considerations that they have to make, the disabilities that they live with, the disabilities that they refuse to live with, the medications they're on, their personal medical history, and all of the things that go into that. And that individual piece is one of the things you reach for when you reach for the knowledge, the skills, and the experience. You think about cases you've seen before. Because I always guess this stat to be about 70%. I don't know that it's written or studied anywhere, but it's possible that it is, and I don't know. But if you think about the amount of education in medicine that is formal and structured, versus informal and unstructured, I'm guessing that it's got to be like 70-30 unstructured to structured. Right? Walking around with your team, talking about cases, interacting with your colleagues, looking stuff up in the moment you need to look it up. These are all the ways that people are truly learning medicine. And I think that we can create a way to match clinical practice and have it align with medical education by taking those individual cases and making them accessible. And that's what we're doing with Figure 1. So this is my model for medical education, is to take cases and dump them in people's brains. But that's because I think that this is the individual unit, this is the atomic unit of medical education, is thinking about an individual person and their struggles and their story and their history and the physiology that is unique to them, because every single case is different. And that's why there isn't such a thing as the ultimate question and answer site for medicine. I was always a little frustrated as a learner that the answer to every single question about what would you do in a case like this, the answer is always, it depends. But it depends on that case, because it depends what pieces of information you haven't gotten yet and what that patient's needs are. And so thinking about individual cases and individual patients, I think, leads us to a much broader and more applicable method of medical education, one that we can deliver now. We didn't have the technology to do it before, but now that we have the technology, right, the mobile device, we can literally put hundreds of thousands of cases in people's hands and in their brains. And that's my philosophy. And that is my presentation.